how to put it across to patients and their relatives if there's a surgical complication. Dr. Shreyas, how would you want to handle this situation?
I think there's no shame in accepting to a patient if there has been a complication. And I think explaining to them about the course of action which is required, and ensuring and giving them the confidence that you are there with them. You will do all that is necessary to ensure that they get back, or you will do everything within your capacity to restore vision. I think that's something which is obviously is part and parcel and is extension of it, and that's usually sufficient. I mean, I've always noticed that hiding a complication is what finally gets us into trouble later. So being quite upfront with them and telling them that this is what is there, this is what is expected, so that when they actually go through that problem, they also realize that yes, doctor already told me that I would be facing these issues, and then you give them the solution. And I think they are the happy patients. In fact, some of the patients who you've had complications in, taken this extra effort, chair time, more visits, end up being your close patients who end up referring a lot more than the regular run-of-the-mill patients who have had uneventful surgeries.
Very well said, sir. Thank you so much. Dr. Rishi, your thoughts on the same?
Yeah, I think Shreyas said it very well. You have to basically be honest with the patient right from the beginning, and the beginning means right after the surgery. So in fact, if it's between two patients also, I will sometimes walk out to the patient's room and explain to them that we've had a little problem and this is what we've done, and we might need to intervene later, and we might have a little bit of a rocky post-operative course. So if at the right at the beginning, if you inform the patient and you keep them posted about the developments, I think that prevents a lot of problems later. If you tell them, say, a week later when their things have gone really bad, that's when they really don't appreciate it. So if you've had a drop, tell them then and there. Or if they've had some rupture of the posterior capsule, which you think they need to know about, then it's best to just inform them that we've had a little bit of a problem, but we've managed it, or we couldn't put in the lens and we will do it at the earliest possible. And this is the reason for it. The patients understand that we are not superhuman, we are human, and they also do understand that mistakes are not often because of us, but because of either their eyes situation or something which is out of our control. So if you've been upfront even before surgery that complications are part and parcel of surgery, and after surgery, if you tell them straight up that you had a problem, I think that itself makes a lot of difference. Second thing is, when you talk to them, your body language has to be humble. You have to not try and come across as very matter of fact. You have to be empathetic. Tech was very nicely alluded to earlier. And it's very important to have some physical contact also. If the patient is in pain, for example, if it's a patient with endophthalmitis, just touch their shoulder, just having a physical touch sometimes makes a lot of difference. So it shows that you care about them. I think that's very important, that you have to convey with your entire body language that you truly care, and you should care, because it is your patient and it is your responsibility. They should feel that you are taking full responsibility, and of course you should take full responsibility. So if you need to refer, if it's a case which you cannot manage at your center, don't delay in referring. If it needs to be seen by a retina specialist, send at the earliest, because many people have lost in court for those reasons only, that they didn't refer in time. So just explain to the patient, and also communicate to the next doctor who's going to be seeing that this patient has had a problem. Please handle them with extreme care. Don't make them wait, and don't charge them. And please please communicate with me what is happening with them. And then after the doctor has seen, maybe you can even give them a call and talk to them. So basically, you have to give them importance. Don't try to brush them off. Don't try to throw it back on them, because ultimately, patient will not appreciate that.
Dr. Somashela Murthy, ma'am, your experience from the LVPI perspective?
So I think many of the points have been beautifully covered by the panelists just before me. Instead of the LVP perspective, I just wanted to bring out that this is one thing that is not taught in residency training. So how to the interpersonal communication and conveying bad news. In fact, it's actually overseas. There are some lessons that are taken for residents in this. And there's so many strategies. And in fact, there's a very interesting write-up which maybe I'll forward to you, and you could send to your young ophthalmologist group as well, on how to address the patients who have these problems, complications, and so on. And exactly most of it, what Rishi says, is what we do in institutes as well. There's a slight variation in how individuals practice. Like some people are blunt and they just say upfront that this is what has happened. Some people break it down stepwise and say that, okay, your surgery is going to take a little bit of time, and then post-operatively you say, okay, you have a little bit of edema or whatever, but you know that there's actually a drop nucleus or something. And then some surgeons do a sort of a very systematic stepwise kind of breaking the news to the patient. So it depends on what the personality the doctor is and what kind of patient you have in front of you. But the dictum is that, yes, share that there's been a complication, and also the terminology, because it's not that we're trying to hide something from the patient, but any patient who has a outcome which is not desirable, they're not seeing well or something like that, they feel a lot of grief and anxiety when you tell them, then you use that word complication. So it's like garbad, something has gone wrong. So the words that we select should be very different. And in fact, in LVP, we of course get a lot of patients who come in because they may be not so happy and they come in with problems. So the first thing they say, "Nahi, doctor ne gabad kiya." So I said, like, look, no doctor goes out to say, "Aaj to main complication karunga. I am going to drop the nucleus today." So every doctor wants to treat you. Do you think they don't want vision for you? Every doctor wants you to get 20/20 on day one post-op, and that is how we operate. So when you say that it's if it's somebody else, your colleague's complication or something like that, so the patient immediately gets diffused or disarmed. He said, yeah, that's true. The doctor doesn't want me to do badly. So yeah, he's there. He's got his degree to help you, he or she. So, but if it's your own complication, so in my case, I tell them upfront, but I don't tell them in the worst possible way. So I always downplay it, because let them at least have a good night's sleep. So I would just say that, yes, the surgery took a little bit longer, and but somehow we managed it, and your eye is actually good, and something in a sugar-coated way. So at least they have a good night's sleep. And when they come in the next day, then we can see what's happening and then take it up. So it's step number 2. And then say if it has to go to the retina surgeon, that's step number 3. And yeah, so I hang on to all my complications, the patients, personally take them by the hand and take them to the retina surgeon, whatever it is, because that's the only way that they'll keep their faith with you and they'll get taken care of also.
Very, very well said, ma'am. Thank you so much. Coming to the seniors, Dr. Grover, Dr. Mehta, and Dr. Luthra, what are your comments on the same?
I think everything has been said. Maybe we can put it in another language. That's all we can do. I think the 2 keywords are honesty and communication. You have to have a communication from the preoperative period. If they are predisposed to certain complications, you have to tell them that they are more likely to get inflammation because they have a uveitis, or that they have a posterior polar cataract, or that they have an endothelial problem. So preoperative communication is very helpful. And also the communication when a thing happens about what the future course is likely to be, as was mentioned. That is again very important. One aspect that has been mentioned by Dr. Somashela, breaking bad news is a very important component of all curricula and all evaluations, as well as to how well you can do it. It's a most important component of the communication skills. And there are several techniques, as she's mentioned. I think one that is used is a sandwich technique. Whenever I start a communication after let's say a nucleus dropped, I say, अच्छा हो गया operation, लेंस लग गया है, कुछ लेंस का पार्ट है जो कि will need to be done by our posterior segment surgeon, जो कि वो आज या कल में कर देंगे, और you are likely to have a good vision. So start with a good news and with a good news. You're likely to have a good vision. There is a 99% chance that you will have a good ending, and the surgery was a little rough. So this is what has happened, but it is going to end up well, very, very likely. Only thing is, it will take a little longer, and your tone has to be very measured, very calm, and you have to be relaxed. You have to make sure that you are making them calm and assured. So that is the crux of managing this. Your tone, and you should not sound guilty. Oh, ye ho gaya, ya ye humse problem ho gaya. So, and even in the later communication ki aap ye uske liye kar doge, it shouldn't be sounding as if you have done a crime or something. It's something that we know is a part of our job. If we have done a surgery, we would have complications. I mean, none of us will end up without having had a complication in our everyday career. So we must get rid of that guilt factor and make sure that you are not showing it to the patient. Measured, calm tone, a good beginning, a good end, and in between, break the bad news gently and firmly and peacefully. That's it.
We've spoken so well, and everybody's covered everything. And I think the only one thing which I thought could be elaborated a little bit upon was documentation. So while everything is important, how to communicate everything, it's equally important to document everything, which includes from the pre-operative time. If you have a posterior polar, as sir said, you must document it. And not only that, you're write down a posterior polar, you also, like the risk of possibility of complications explained, possibility of a second surgery explained, rare chance or whatever. And then if you have a complication, make sure that you document it in your EMR, also on the patient sheet. There have been instances where patients said that, while I was not told anything and nothing was put on my prescription to tell that, there was some complication. So I think that's equally important to document it at every step. And also, of course, we've covered everything so well. And as sir said, that don't try to show that you've been guilty, because, frankly, some people can go on the defensive and
Don't
that can make
feel
things
guilty.
worse.
If you
Right.
feel guilty, you will communicate it, because you should not be feeling guilty for it. That's
Absolutely,
something
sir.
that we have all to learn as professionals. This is a part of our profession, but unfortunately, it does happen. I don't know why.
So actually,
Lawyers
sir, we
will
feel
have
bad, but
cases
we
of
should not
failure,
feel
but
guilty.
they'll not show a guilt, right?
I think we have to empathize, and and also, you have to feel bad that, okay, you got a complication. That's part of nature. If somebody has a problem and your patient has a problem, you feel bad about it. You don't want them to have a problem, so it's okay to feel bad, but to express your guilt or kind of in front of the patient, expressing the fact that you made a mistake or something can be counterproductive. Yet, on the other hand, if you have a smirk on your face when you tell the patient about a complication, that can be counterproductive too. So if you are indifferent and if you tell the patient about a complication in a very indifferent way and in a non-calent kind of way, you can then create a problem as well, because then they feel that you're not kind of bothered about what they've had. So it's both sides have to be kind of tackled, and then good documentation. But I think everything else is so well covered that I don't want to add anything beyond that.
Grover said, Dr. Gaurav said, so very important. Dr. Grover, sir, this is the difference between a lawyer and a doctor. We have something called conscience, and we are conscientious people. A lawyer loses a case after charging for his brief for 10 crores, none of your Supreme Court guys in Delhi would even blink an eye. They would never bother if we have lost a case. They get the briefing at the last minute, and per hearing they might charge you 50 lakhs or whatever, and we are scared to even charge 50 rupees here. That's the unfortunate part. But, one of the things that I've seen, a lot of people show videos outside to the families. And when the complication occurs, suddenly the video switches off, or, then they switch off again and switch on. You are giving them a chance to record all this. And that is something disastrous. And everybody has a cell phone. People are recording all these things. So be careful when such recording is going on. Why do you want to show off? Let them see some more movies outside. Let them see something better, some National Geographic, or what's going on in the Shark Kingdom, rather than what's going on inside your theater. Your hands are trembling, you are in problem, and what you will do when the television monitor is on will be different from what you do when it is off. You might do something else totally. You might do something different, but unfortunately, you might be guided to do something wrong when the television monitor is on, and you will switch it off. They will know some problem has happened. And I have had patients who have come to me that वहाँ video चालू था, सब कब 7 मिनट में हो गया, मेरे लिए तो पौना घंटा रखा, बीच में चालू हुआ, video बंद हो गया वापस. So you can be blamed for that, and be very careful when all these video scenes are there. There is nothing to show off over there. Your machoism, it's fine. You are in trouble. Be forthright. Be important. Very important. You could take this up as a very important.
Regarding the video demonstration of surgery, live demonstration of surgery, as on today, with the medical legal things coming up in this era, what is the consensus and what are the other panelists doing as of today? Gaurav and Rishi and Somashela and Shreyas.
So are you talking about live surgery like in conferences,
Live,
or
no.
live
I'm
display
talking
of
about
surgery from
surgery
your
as
own
you're doing it in your day-to-day practice. Are you showing it today?
No, sir, I would
Not
never do
anymore.
that.
We
No, I
used
would never
to
do that.
Many years ago, but we've stopped.
Can be a major problem. Moreover, I think what Dr. Himanshu said, I think, it has gone to the next level now, because, devices to record, everybody has a phone which can take video recordings of everything. They can record all that you say. So whatever you say, not only in the video demonstration, sir, I think even in the OPD, whenever we are talking, so many times there are patients who are attendants, they are recording the whole thing, because, and you should always assume and presume that whatever you are speaking in the OPD to a patient or to anybody in the hospital can be recorded and can be used against you, and can be so, or is being recorded, So I think we have to be very measured in what we say, because anything can be recorded and it can come back to you in a very bad way. That's one big lesson for everybody, I think. So, but no display of videos in our hospital, and I don't agree with it, sir, at all.
I totally agree.
We show all our surgeries, sir, across all centers, and all surgeries are shown, cataract, refractive, cornea, and there are different displays, and it's a novelty. I don't think most patients understand what's going on, whether we are doing a good job or a bad job, whether the phaco is in the bag or is in the anterior chamber. But I think it just serves as novelty. Most of the patients, because there are multiple ORs, multiple surgeons operating, they don't even know whose surgery is being displayed at this point of time. So most of the time, it hasn't resulted in a problem for us till date, because of the fact that we are showing surgeries. In fact, probably patients feel that we are transparent enough to show our surgeries, so they must be doing a good job. So it's just a very soft marketing tool, I would say. but hasn't caused any problem till date.
I think the key is that you're not letting people know who's getting operated. When a patient knows that whose surgery is ongoing and they can tell, then it's probably possible that the attendants outside might feel that, oh, this is my patient. And frankly, there may be a small little thing like seeing a small drop of blood on the conjunctiva, and to them it can appear to be a very, very big problem. Or if they see the duration, as sir said, that the duration was more for one particular patient, or something different about a particular eye where the shape of the pupil was different, or whatever, they might not understand that it is. So I think the key, when you say that you're showing surgeries, is multiple ORs, maybe rotating cameras, and kind of displays changing every few seconds, and not being able to know who's being operated, then it makes sense. But if patients know who's being operated and they kind of have that interest in what's going on, I don't think that's a very, very safe idea.
I think many of us have gone through that phase and have discontinued for a reason.
Yeah, we did that for a few years, and
Yes.
then we stopped doing it. Yeah,
I'm totally against it. Totally against it, because I've saved my colleagues from medical legal cases by only telling them, only like Dr. Somashela said. I said no doctor will survive for so many years, and has, even if there is a jallad, no, the best thing what I do about these multiple infections that we get, I tell them, even if they call a jallad, you can't remove 10 eyes. So this poor doctor has been framed in a camp where he took zero money, and despite that he has been framed. So like that, you have to say our colleague, second opinion. That is very important what she said, that we should be given and showing videos.
On the other hand, I think it's a great idea to record all surgeries, because that can save you sometimes. If you don't have to disclose that you're recording, but I record all surgeries, and later on, if you don't need it, maybe a few months down the line, it just gets deleted automatically.
Can
that's
even display recorded surgeries, sir? I mean, if that's what you are getting at, I mean, as if you feel you don't want to show live surgeries, you could show a deferred live. And
a lot of people do that. I've seen that in Dr. Mohan Rajan's clinic. He has, I think, videos running. If I remember right, he doesn't show live surgeries, but recorded surgeries running in his waiting room, which is pretty okay.
I agree. That part I agree with. Shreyas, what you said makes sense, actually. I'm not saying that it's not a great idea for, kind of giving them a message about, doing good stuff. But probably patients should not know whose surgery is being telecast. That's all I'm saying.